Imagine spending 3 entire years of your life feeling like the room around you is just violently spinning.
Oh, that sounds absolutely miserable.
Right. And not just a little lightheaded either. We are talking about the kind of intense, debilitating rotation that literally throws you to the floor. It makes you severely nauseous. And, that was the daily reality for a 65-year-old woman that we'll call Mrs. Williams.
3 years of that is just, it's a terrifying amount of time to live in that state.
It is. For 36 months, she basically lived in this agonizing diagnostic limbo. She bounced between multiple clinicians. She had her blood drawn over and over again. She was shoved into CT scanners. She went through multiple MRI machines.
And let me guess, they probably put her on a ton of different medications, too.
Oh, absolutely. A heavy cocktail of drugs.
Right.
And her medical bills, they racked up to over 6,500 pounds.
And through all of that time and the money and, the radiation from the scans, she found zero relief, which is actually what makes the resolution of her case study, this is from Dr. Bashir's clinical lecture, it makes it so striking.
Yeah, because after 3 years of sheer misery, the actual cure took, less than 15 minutes?
Yeah, less than 15 minutes, and it happened right at the side of a bed. There were no million-dollar machines involved, no surgical tools, no drugs at all. The total cost of the treatment that finally gave her life back was practically zero.
Okay, let's unpack this. Because what on earth was wrong with her? And I think more importantly, how did so many highly trained medical professionals just miss it for so long?
That is exactly what we need to figure out today.
Right. That is our mission for this deep dive. Today, we are looking at benign paroxysmal positional vertigo, or BPPV. And we're pulling from Dr. Bashir's clinical lecture notes some really great instructional medical guides from Healing Vertigo, literature from the Cleveland Clinic and patient.info, and also a rather alarming 2016 study on head trauma.
It's an incredibly important condition to understand because, BPPV is the most common inner ear disorder in the world. It accounts for roughly 20% of all dizziness presentations in clinical practice.
Wait, really? 20%?
Yeah. 1 in 5 people evaluated for dizziness has this specific issue, and it most commonly affects people in their 50s, 60s, and 70s.
Which means, if you are listening to this right now, the statistics say you will likely experience this yourself at some point, or you absolutely know an older relative who will.
For sure. Everyone knows someone who gets dizzy spells.
Exactly. And understanding the hidden mechanics of what is actually happening deep inside the inner ear could literally save you years of crippling anxiety, keep you out of expensive MRI machines, and crucially, prevent dangerous, life-altering falls.
To really get to the bottom of this, though, we first need to look at how patients and doctors communicate about the problem. Because when a patient walks into an emergency room and just says, "I feel dizzy," that creates an immediate diagnostic hurdle.
Yeah, I would argue dizzy is probably one of the most useless words in the English language when it comes to medicine.
It really is.
It's just a massive umbrella term. Based on the patient.info breakdown, we know that if a patient feels like they might faint when they stand up quickly, that is a blood flow issue.
Right.
A systemic drop in blood pressure, or maybe POTS, or anemia.
Right, that's clinical lightheadedness.
Yeah. And then if they feel generally unsteady on their feet, like they are walking on a boat, that could be a nerve disorder, like peripheral neuropathy or just general aging and frailty. Unsteadiness is totally different.
Exactly. But true vertigo, which is what Mrs. Williams had, is entirely different from both of those. It's a highly localized hardware glitch.
Oh, I love that analogy. It's like lightheadedness is a power brownout in your house. Unsteadiness is like a bad Wi-Fi signal to your legs. But vertigo is a faulty motion sensor alarm just blaring for no reason.
What's fascinating here is that true vertigo is almost always an inner ear problem. It is the physical, undeniable sensation of environmental rotation. It is literally a hardware failure in your body's motion sensors.
Here's where it gets really interesting to me, the actual anatomy of it.
Right.
Because to understand the hardware, we have to look past the eardrum.
Right. Deep inside your ear, past the tiny bones that process sound, there is a vestibular organ called the utricle.
And the utricle is basically a tiny fluid-filled pouch. But what's inside the pouch is what blows my mind. Because we literally rely on microscopic rocks to keep us balanced.
We actually do. It sounds crazy, but the utricle contains tiny calcium carbonate crystals called otoconia.
which is basically chalk, right?
Yeah, essentially. And they sit on top of these very delicate little hair cells. Their entire biological purpose is to detect linear acceleration and the pull of gravity. So, when you ride in an elevator moving up or when you lean your head forward, gravity physically pulls on those heavy microscopic calcium crystals.
And they weigh down the hairs beneath them, right?
Exactly. The hairs bend, and that bending shoots an electrical signal to your brain saying, hey, we are tilting forward or we are moving up.
Okay, but wait, I have a mechanical question about this. If these crystals are just calcium carbonate and they were just sitting in fluid all day long, why doesn't the body just dissolve them? I mean, we dissolve minerals all the time.
That's a good question. So the inner ear is a highly specialized closed environment. The fluid in there, it's called endolymph. It's heavily saturated with potassium and other ions. It's specifically calibrated to maintain an electrical charge for the nerve signals, not to act as a solvent.
Oh, I see. So the environment preserves them.
Right. The crystals are relatively stable in that fluid. However, they are tethered in place by a gelatinous membrane. And, well, that membrane can degrade over time.
Which leads us to the actual glitch. Through the normal wear and tear of aging, or maybe an infection like vestibular neuritis or even just prolonged bed rest, these otoconia detach from the membrane. The microscopic rocks break loose and just become free-floating debris.
Yeah, and the problem isn't just that they detach, it's where they migrate to. Adjacent to the utricle are the semicircular canals.
Right, we have 3 of these in each ear.
Exactly, and they function essentially as 3D fluid-filled gyroscopes. You have one for upward motion, one for downward, and one for horizontal rotation.
So it's kind of like a microscopic snow globe in your head, and the snow accidentally gets flushed into the wrong pipe.
That is a perfect way to picture it, because under normal circumstances, when you turn your head, the fluid in these tubes sloshes around, pushes a little flow detector called a cupula, and tells your brain your head is turning.
But when those heavy calcium crystals fall out of the utricle and drop into the semicircular canal, which is usually the posterior canal, right, because gravity just drags them down there.
Yes, the posterior canal is the most common, and once they're in there, they completely alter the fluid dynamics. Now, when you turn your head, the fluid moves, but those heavy rocks also roll through the fluid.
Like dropping a boulder into a really narrow stream.
Exactly. It creates a massive, exaggerated wave. So your brain receives this blaring emergency signal saying, we are violently spinning. But simultaneously, your eyes are looking at the room and telling your brain, we are sitting perfectly still in a chair.
And that intense sensory mismatch is what causes the profound nausea and the vertigo.
Right. Now, Dr. Bashir's clinical notes break this pathophysiology down into 2 specific models of how these rocks actually cause the chaos.
Okay, let's look at the first one, which I think accounts for about 90% of all cases, right? Canalithiasis.
Yeah, canalithiasis. In this model, the dislodged crystals are just free-floating in the canal fluid. When the patient moves their head, gravity begins pulling the crystals down the curve of the tube. But, they have to overcome the friction and viscosity of the fluid so they don't move instantly.
Which explains the incredibly specific timing of the symptoms. Because a patient gets into bed, their head hits the pillow, and the room doesn't spin immediately. There is a little lag.
Yes, the clinical term is latency. There is typically a 5 to 15 second latency period before the vertigo hits. And because the crystals eventually settle at the bottom of the curved canal, the spinning sensation is short-lived.
So it usually fades in under 30 seconds. It's totally terrifying, but it is brief.
Exactly. It fatigues quickly.
But so the delay makes sense if the rocks have to push through the fluid to reach the bottom. But what if they don't float? Like, what if they somehow get stuck?
That brings us to the second, much rarer model, cupulolithiasis. In this scenario, the particles migrate into the canal and actually get physically stuck to the cupula itself, that delicate little sensor that detects fluid flow.
Oh, wow. That sounds like an absolute nightmare.
It is.
Because if the heavy rock is glued directly to the sensor, then the system is going to become instantly sensitive to gravity.
Exactly. The latency disappears. Symptoms occur immediately upon head movement. And because the sensor is constantly weighed down by that stuck crystal, the vertigo is far more persistent. It doesn't fatigue or fade out quickly like the free-floating model.
Man. Okay, let's bring this back to our patient, Mrs. Williams, and the systemic medical issue her case really represents. Because we just established that BPPV is a purely mechanical plumbing issue. A microscopic rock falls into the wrong fluid-filled tube.
Right.
And we also know from the epidemiology that it accounts for a 1/5 of all dizzy patients in the clinic. So why is the diagnostic delay so severe? Dr. Bashir notes the average patient sees 4 to 5 physicians over many months or years before getting a correct diagnosis. Why are doctors missing the rocks?
If we connect this to the bigger picture, it exposes a massive philosophical flaw in how emergency medicine approaches dizziness today.
How so?
Well, the current medical culture heavily relies on high-tech defensive medicine. When a patient arrives at the ER complaining of intense, sudden onset dizziness, the immediate concern is ruling out central neurological diseases. The doctor's primary fear is this patient having a stroke? Do they have a brain tumor, a hemorrhage?
They jump to the worst case scenario, which is fair. That's what you want an ER doctor to do. You want them to make sure you aren't actively dying.
True, absolutely. But the problem is how they go about ruling it out. BPPV is a bedside diagnosis, but doctors treat it as a diagnosis of exclusion. They order these incredibly expensive CT scans and MRIs of the brain looking for diseases instead of testing the ear.
Right, because BPPV is a mechanical issue in the inner ear cavity. It's just not going to show up on a brain scan.
Exactly. The brain itself is perfectly healthy. So the scans come back clear, the physician shrugs, prescribes a symptomatic medication like an anti-nausea drug, and just sends the patient home.
They are essentially taking a photograph of the car engine to figure out why the tires are flat.
That is a brilliant way to put it.
And this reliance on imaging over physical examination gets even more alarming when you look at head trauma. We pulled a 2016 study by Khalid and colleagues for this deep dive. They looked at secondary causes of BPPV and found that 28% of patients who suffer head injury end up developing this condition.
Which, from a biomechanical standpoint, makes perfect sense. The otoconia are fragile. If you sustain a significant impact to the skull, the sheer kinetic force is going to knock those calcium crystals right off their membrane in the utricle and send them flying into the semicircular canals.
Yeah, but here is the knowledge gap that study exposed, and it is honestly startling. They surveyed 91 physicians at Hamad General Hospital in Qatar.
Okay.
And these were doctors working specifically in emergency medicine, neurosurgery, and orthopedics.
Yeah.
The exact people managing head traumas. And out of all of them, only about 30% said they routinely check for BPPV in their head injury patients.
Wow, only 30%. Did the researchers dig into why the overwhelming majority of trauma doctors were just ignoring a condition that affects nearly a third of their patients?
We did. And 73.6% of those doctors openly admitted they simply lack the knowledge and the specific training to manage it.
That is wild.
Right. Now, optimistically, over 91% stated they actively wanted to receive that training. But it really highlights how siloed modern medicine has become.
Siloed is exactly the right word. Because, a neurosurgeon is trained to look at the CT scan for subdural hematomas or skull fractures. An orthopedic surgeon is analyzing cervical spine stability.
Right.
The inner ear is historically treated as the domain of the ear, nose, and throat specialist, the ENT. So unless an ENT happens to be standing right there in the trauma bay, this incredibly common, debilitating condition just slips right through the cracks.
The major takeaway for anyone listening is this. If you get into a car accident or take a bad fall or, get a concussion and you start feeling violently dizzy every time you lie down or roll over in bed.
Your doctors might just assume you have lingering brain damage from the concussion.
Exactly. They might tell you it is post-concussion syndrome. But there is a very real chance it is just the calcium crystals getting knocked loose by the impact. Your neurological hardware and software might be completely fine. You just have a rock in the wrong tube.
Which is an incredibly empowering piece of knowledge, I think, because unlike a traumatic brain injury, which can be devastating and very complex to treat, BPPV is a bedside diagnosis. You don't need a $1 million machine. You just need a clinician who understands human anatomy and knows how to perform a simple physical test.
So what does this all mean for actually fixing it? Let's get into the mechanics of that test. How do we actually prove this without the MRI? Because Dr. Bashir emphasizes a specific technique invented back in 1952, right? The Dix-Hallpike maneuver.
Yes, the Dix-Hallpike remains the absolute gold standard for diagnosing posterior canal BPPV. Though, as Dr. Bashir's notes point out, before a clinician even touches the patient, they must do a safety check.
For the neck, right?
Right. They need to ensure there are no cervical spine issues or vertebral artery risks because the test requires moving the neck rather quickly.
Okay, so assuming the neck is totally safe, what happens next?
So the patient starts by sitting upright on an examination table. The clinician turns the patient's head 45 degrees to one side. And this specific angle is crucial because it perfectly aligns the posterior semicircular canal with the gravitational plane.
Got it.
Then the clinician supports the patient's head and quickly lays them back so they are supine lying down, with their head extended about 30 degrees below the horizontal edge of the bed.
So they basically drop the head back off the bed and let gravity do the work, and then the doctor just stares deeply into the patient's eyes.
They do. They are looking for nystagmus. The patient is instructed to keep their eyes wide open. If they have BPPV, dropping the head back forces that rogue crystal to slide down the canal. The fluid sloshes, the sensory alarm bells ring, and the brain panics, thinking the body is falling or spinning.
And the brain immediately tries to stabilize your vision based on that fake signal. That's the vestibulo-ocular reflex, right?
Exactly.
Your ear tells your brain you are moving, so your brain fires the eye muscles to track the movement.
That is the reflex in action. But because the signal from the ear is a continuous false alarm of rotation, the eyes start twitching and darting involuntarily, trying to catch up to a spin that isn't actually happening. That twitching is the nystagmus.
I think it is absolutely brilliant that the eyes literally draw a map to the problem. Because the twitching isn't just random, is it? Dr. Bashir notes they are looking for a torsional upbeating nystagmus.
Right. The eyes essentially rotate and beat upward toward the forehead. The direction of the twitching is highly specific to the geometry of the canals.
So the eyes give away the culprit.
They do. If the clinician gets that torsional upbeating nystagmus when the patient's right ear is pointed toward the floor, it mechanically proves the crystals are trapped in the right posterior canal.
That is so elegant.
And the duration of the twitching will also tell the doctor if it is the free-floating canalolithiasis model or the stuck cupulolithiasis model, just based on how fast the twitching stops.
Right, less than 30 seconds for the floaters and persistent for the stuck ones.
Yeah.
Now, before we get to how they actually fix it, the sources outline some very strict red flags. Things that prove the dizziness is absolutely not caused by these ear crystals.
Oh, this differential diagnosis is critical. BPPV is strictly a mechanical issue with the balance organs. It does not affect the cochlea, which is the organ responsible for hearing. Therefore, BPPV does not cause hearing loss. It does not cause tinnitus, which is ringing in the ears.
So if a patient has vertigo and ringing ears, what is that?
That points toward Meniere's disease or maybe an infection. Furthermore, BPPV does not cause central neurological symptoms. You will not experience double vision, difficulty speaking, facial drooping, or weakness in your arms and legs.
Okay, so if a patient presents with vertigo plus any of those neurological signs,
the bedside test stops immediately. That patient urgently needs the MRI because you are looking at a potential stroke or central brain lesion.
right? But if there's no hearing loss, no weakness, and the vertigo is purely triggered by head position, it's the crystals. Which brings us to the cure. This is where Mrs. Williams finally got her life back. It is an 80 and 90% effective physical therapy exercise called the Epley maneuver.
And the Epley maneuver is pure biomechanics. Instead of masking the nausea with drugs or trying to surgically intervene, it just uses gravity to solve the plumbing problem.
The best way I can visualize the Epley maneuver is to picture one of those wooden labyrinth games. You know, the ones with a little steel ball bearing?
Yeah.
And you have to physically tilt the whole wooden board to roll the ball through the maze without it falling into a hole.
That is exactly what the clinician is doing. The patient's semicircular canal is the labyrinth and the calcium crystal is the steel ball bearing.
So walk us through the steps based on the Cleveland Clinic and Healing Vertigo guides. The sequence starts in the exact same position as the Dix-Hallpike test, right?
Right. The doctor drops the patient back with their head over the edge of the bed. That initial tilt forces the crystal to the bottom of the loop.
But they can't just sit the patient back up, because if they do, the crystal just falls backward into the exact same spot it started.
Right. They have to keep pushing it forward through the curve. So after waiting about a minute for the fluid to settle.
That wait is important, right?
Very important. You have to wait for the crystal to settle. Then the clinician gently turns the patient's head 90 degrees to the opposite side. They tilt the wooden board again, essentially rolling the crystal further along the anatomical tube.
And then the patient rolls their entire body onto their side, turning their head even further down so their nose is actually pointing at the floor.
Exactly. The ball bearing rolls to the very edge of the exit.
And finally, keeping their chin tucked, the patient sits up. Gravity drops the crystal out of the narrow semicircular canal and dumps it right back into the wide open pouch at the utricle.
Where it can be safely reabsorbed or broken down by the body's natural processes. It is a profoundly elegant solution.
It's amazing. Now, after the maneuver, clinical guidelines typically advise the patient to rest.
Right. Yes. Usually to sit quietly and rest for 10 to 15 minutes. The vestibular system has just been subjected to intense, conflicting signals, and the brain really needs a moment to recalibrate and let the fluid dynamics settle completely.
Okay, but what happens if the doctor does the initial Dix-Hallpike drop, and the patient gets dizzy, but the eyes don't do that specific upward twitching? What if they twitch, I don't know, side to side?
That indicates the crystals didn't fall into the posterior canal, they fell into the lateral or horizontal canal.
Ah, okay.
And this requires a different diagnostic setup called the supine roll test, where the patient lies flat and the head is rolled side to side. You cannot use the Epley maneuver to fix lateral canal BPPV because the geometric pathway of the tube is just different.
Right, the labyrinth is a different shape.
Exactly. So the clinician has to use different gravity pathways, utilizing maneuvers like the BBQ roll, the Guffoni, or the Cassani maneuver.
It's just a different wooden labyrinth board requiring a different sequence of tilts to get the ball bearing to the exit?
The underlying principle is identical. You map the specific tube by watching the eye movement, you understand the physics of gravity, and you roll the rock out.
It really is an incredible journey when you step back and look at it. I mean, this condition, BPPV, is responsible for thousands of dollars in wasted medical tests per patient. It causes immense psychological distress because the patient feels like their brain is literally failing them.
Yeah.
Yet it is nothing more than a mechanical plumbing problem. A microscopic rock breaks loose, falls into a gyroscope, and sends fake signals. And it can be diagnosed completely free of charge just by looking at how the eyes twitch and cured by a 15-minute sequence of head turns.
This raises an important question, though, about how we practice medicine today. We have created a healthcare ecosystem that reflexively equates high technology with high diagnostic accuracy.
We really do.
When both doctors and patients are confronted with a terrifying, dramatic symptom like violent vertigo, the psychological comfort of the MRI machine is incredibly seductive. We want the definitive, high-resolution scan.
We want to see the problem on the screen.
Exactly. But in our rush toward defensive medicine, we often overlook the brilliance of the body's physical design. The most effective solution here requires absolutely no technology, just a profound understanding of human anatomy and a willingness to trust the physical examination.
It definitely puts our reliance on technology into perspective.
Yeah.
And, I want to leave you, the listener, with a final thought to mull over as you go about the rest of your day. The next time you feel like your entire world is spinning out of control, when your reality feels completely unmoored and terrifying, remember the mechanics of the inner ear.
Yeah, that's a great point.
Because your brain's entire perception of reality, your fundamental sense of gravity and balance, can be completely hijacked by a microscopic grain of calcium being just a single millimeter out of place.
Yeah.
It really makes you wonder, how many of our other profound, overwhelming human experiences, the things that feel like massive, insurmountable crises, are actually just the result of a tiny, unseen mechanical glitch?